This week on the Backtable podcast.
Just this week, I had some discussions with UT System healthcare economics people about expensive pharma drugs in Texas. And they're seeing this explosion of cost because people are being always moved to the next new expensive treatment without really figuring out, well, who really needs it? And so that's the gap. I mean, I don't know how we really fill that. I mean, that gap right now, I think the first step is to admit it's a gap. We're not really talking about that much, but I think that really needs to be, you got to admit you have a problem first before you can start developing a solution. So we got to admit there's an issue there.
Now, a quick word from our sponsor.
Did you know that up to 18% of maxillary sinus surgeries might need a revision, and that patients can experience a decrease in the diameter of the frontal sinus ostia by 38% within 13 months post-surgery? These challenges can lead to suboptimal outcomes following traditional endoscopic sinus surgery. Medtronic understands these complications. That's why we recommend the Propel family of implants for adult patients with chronic rhinosinusitis following ethmoid, frontal, or maxillary sinus surgery. Propel is not just a tool, it's a two-in-one mechanism that is clinically proved to improve patient outcomes by maintaining sinus openings while delivering a powerful corticosteroid mometasone furoate directly to the sinus tissue. Are you ready to elevate your practice offerings and patient care? Contraindications include patients with confirmed hypersensitivity or intolerance to mometasone furoate MF or hypersensitivity to bioabsorbable polymers. Visit medtronicent.com to learn more about Propel.
Now, back to the show.
We are very lucky to be joined today by Dr. Martin Citardi. He's a world-renowned rhinologist and skull-base surgeon and professor and chair of the Department of Otolaryngology at the McGovern Medical School, which is part of the University of Texas Health Science Center at Houston. And he's here today to talk to us about what's new in the management of nasal polyps. Welcome to the show, Dr. Citardi.
Good morning. Thanks for having me.
Thanks for coming on. Can you first tell us a little bit about yourself and your practice?
Sure. Well, I'm a fellowship-trained rhinologist. I completed fellowship back in the late 90s. I've been in academic practice my entire career. I became department chair in 2008 and then vice dean for clinical technology about 5 years ago. And my practice has really spanned what I call the development of peak rhinology. And I've had experience both with direct patient care and sort of challenging situations, but also some of the socioeconomics, practice management issues, device development, even drug development a little bit. So I think I have a pretty unique, comprehensive perspective on really almost anything that touches rhinology.
You know, in regards to nasal polyps, which we're talking about today, before we get started, in a nutshell, what's the kind of the progression been as, over your practice over these last several years from when you trained to kind of like how we think about it now?
Yeah, well, in the early endoscopic era, before I actually started training, was all about polyp removal and just basically removing masses from the sinuses. Everyone knew steroids helped, but the early days was just a lot about the technical aspects of sort of efficient, safe tissue removal, basically. And then after that had been achieved, it became clear we needed something else. And people were using steroid tapers, and then we added on steroid irrigations and other ways of delivering topical steroids into the nose and sinuses. And that leads to, things like budesonide irrigations, which is just a mainstay of something that we've used really extensively now for probably almost 20 years in various forms. And then about 5, 6, 7 years ago, Biologics came on the scene, steroid delivery devices shortly before that, and also exhalational delivery of steroids as well came on about the same time. And all of those things have really added a lot more to what we offer patients.
Yeah, I feel like there's been, especially an explosion in the last 5 to 7 years with the advancement of biologics, and sort of has really kind of, changed or given us new options in terms of how we manage nasal polyps and how we counsel patients of expectations. But before we get into that, can you tell us in your practice, and it sounds like it's a quaternary, academic care practice, but how do patients with nasal polyps usually present?
So even though I'm in an academic practice, we see a full range of patients. And for instance, all of our appointments are available online for open scheduling. So I do see primary patients as well. But most patients with sinusitis with nasal polyps they report congestion, obstruction, but they are not horribly vocal about their symptoms, which is kind of interesting. The nose will be swollen shut with polyps, and they say, oh, I'm a little bit stuffy, I'm a little bit congested, I wheeze a little bit, but they're not vocal about it. And to me, that's always been fascinating. Many of them have sense of smell, but they usually don't lead with that symptom. You have to sort of elicit it from them. But they're relatively minimally symptomatic compared to the other patients we see in rhinology.
Yeah, I've noticed that too, and I think it's really interesting just in general how we think of, like, sensation of nasal obstruction and nasal airflow because you're right, you can look in there and it can be you can't even fit the scope anywhere, and it's like, can you you can breathe through your nose or you can't breathe
They're
through your
here for
nose?
otorrhea, like,
Yeah,
they're here for something
right.
completely different. It's like, and I don't know, is it a reflection on the slow growth of polyps? I feel like they grow so fast after surgery. You know what I mean? Sometimes you're like, "Wait, how did that reappear so fast? How does their nose get so how do they accommodate to their mouth breathing or get used to their symptoms? Or why do you think it is?"
The best explanation I heard, I don't know if this has actually been validated, is they get substance P depletion. So just by over-sensory stimulation, eventually the trigeminal innervation just sort of attenuates itself. And that kind of makes sense. I don't know if it's actually true, but it does make sense.
Yeah, that's really interesting.
Yeah, I'm like, does that substance P get refilled after surgery or when their nose clears up on rinses and things?
I don't think so because they tolerate quite a bit in terms of endoscopic debridement, even after, when they're doing well. I mean, the nose is just very tolerant. Now, some of that is the nose is larger, right? The polyps expand the space. And so there's more room to work in, but they remain relatively, I don't want to say numb, but in a sense, numb in their nasal and sinus lining.
And so in these appointments, let's pretend we're talking about the patient that didn't know they had nasal polyps and they were just coming to you because they're like, I'm a little congested. I think my allergies are flaring up. And then, how does the rest of that visit go?
Well, we try to get a detailed history in terms of the onset, inciting factors. These days, many patients will have report some prior treatment over the counter nasal steroids. There's a lot of different things patients will try before they get to us. Since this is mostly a quality of life disease, I think it's important for the patient to define what their objective is because we could achieve our objective as physicians, but if it doesn't align with what the patient wants and it's all about quality of life, that there's a problem there. Now, sometimes when their objective is completely misaligned to the things we can help them with, I think we need to have that conversation as well. So the patient who comes in with a little bit stuffy, but their main complaint is pain in the back of their head. Well, no amount of things we're going to do to improve their nasal airflow is going to change the pain in the back of their head. And we need to have that conversation up front. And so I think that's really important.
Yeah, sometimes patients have a constellation of things going on and they can just assume that they're all connected. And then the nose is better and they're like, yeah, but I'm still having, these headaches, these sinus headaches, and they point to the back or, and you're like, oh, yeah, that's not part of it. That's a really good point. So do you like to use questionnaires when you like validate questionnaires as far as like determining quality of life impact and things like that or
So we do have them on paper currently. We're exploring them moving to a digital format. Personally, I don't think they're terribly helpful because it doesn't give me what I need to understand what's driving the patient behavior and what gives them the most trouble. There's a lot of noise in the questionnaires about that's not directly disease related. It's more behavioral, and that clouds the picture. I also think there's a problem with the quality of life questionnaires in that we tend to use them for diagnosis, and that's not their intent. They assume that the population who's taking the questionnaire has the confirmed disease process, and then it gets valid too. So I think it's very easy to misuse them. So we do it, but again, practically, I don't think it's super helpful in most patients.
No, it's interesting you say that. I found in my practice with sinus patients, I always had a hard time of the logistical stuff of, like, collecting the data. where to kind of put the data, how to access the questionnaire, and then how was I gonna use it? Like, is it gonna affect my decision making? And the noise, like, in some of the questions, sort of where to put that in terms of the overall picture, whether it was in the sinus picture or, what else was going on. And so I've kind of have never quite figured out how to kind of utilize it, I think, efficiently in my practice.
Well, the logistics are difficult, right? Because you want to
Yeah.
do it digitally these days, but even the workflows around that, and one of my other hats, they're not clean.
Yeah.
We're looking at that now in our practice, and maybe I'll let you know how it goes in a few months. But I don't know how much success we're going to have, to be honest with you.
So tell me a little bit about your exam. So do for a primary patient who comes in surgery naive, they're able to see you, you're thinking, okay, this patient's here for nasal obstruction, maybe some drainage. We think this is, a sinus reason. What's part of your exam? Do you like rigid scopes for these patients? What's your enteroscopy like?
Right. Well, I'll back it up a little bit. I think my exam starts from just observing the patient to begin with, right? You can learn a lot about what's giving people trouble by their behavior and verbal and nonverbal cues and their family member who's in the room with them. Again, for quality of life disease, that's super important. The other thing is, many of these patients, if they have like loss of nasal tone in their voice, you can almost hear the nasal polyps before you look. Sometimes there are subtle differences and there's some facial asymmetry. One eye is a little bit proptotic and the patient never notices it. And if you're looking at them from a bit of an angle, you wouldn't notice it either. And so those things help. But beyond that, I mean, everybody gets an endoscopy. I use pretty much exclusively rigid scopes. I record almost all the exams onto our image archive that we have available, sometimes for just patient education, sometimes for checking progression. For me, it's more meaningful to look at the video from a prior visit than to read the description, that we have in the chart. And so we have that available for us for each encounter as well.
Do you like to decongest or spray?
Not routinely. I know I'm an outlier in that curve. I think, the sprays themselves are not super comfortable for patients. They taste bad, they cough and sputter, and the exam is super brief. The effect of the numbness in the throat sometimes is more discomforting than the, quick, 2-minute scope. But in polyp patients, they don't really feel much in the nose anyhow. And so in this patient group, it doesn't matter. I mean, spraying, it's not going to add anything more.
Yeah, and sometimes like the tip that it's polyps is when you try to spray their nose, everything just comes right back out.
There's no place for it to go.
It
Exactly.
just doesn't even go in. Anything else that you do in particular as far as, with your scope exam or any other physical exam?
I usually use a 30-degree telescope almost exclusively to start with, and then move up to a 45 or a 70 for frontal or maxillary views. But in a patient with polyps, it's a 30-degree scope. I've moved to using the 3 millimeter versus the 4. It's just a little bit more comfortable for patients, especially if you're not spraying. Again, that's not as much of an issue in polyp patients because they just tolerate more. But you can get a really good view with a 30-degree 3 millimeter scope hooked up to to standard office camera. And so that's sort of the workhorse now.
Yeah, that 1 millimeter really, like even when, like if I've been using a 3 and then I use a 4 for whatever reason, like suddenly I'm like, oh my gosh, it's huge.
So big.
Yeah, it's a huge difference. It's also interesting when you go down a notch too. The 2.7 so-called pediatric scopes are a lot more fragile. There's something about 3 that is sort of that magic sweet spot between a good image and good durability and just a better patient tolerance for it.
Yeah, that point 3 millimeters. That's crazy, right?
Yeah.
And what are you seeing on your scope exams in the nasal polyp patients?
So we try to categorize the type of polyp. Okay. And so a lot of that I think is hand waving, and you kind of go back retrospectively and you can say, well, this is a neutrophilic polyp versus an eosinophilic polyp. But we try to make a pass at that. Sometimes you can get clues by the colors of the secretion. So if there's sort of that golden yellow crusting, that's going to be more eosinophilic. If your polyp is more hyperemic, that's going to give you a clue. I mean, sometimes I'll talk about, cystic polyps, which are sort of like grapes. They're just fluid filled, and other ones are more fleshy. All those things I think are are helpful data points, but not in the instant in which you're doing the exam. You have to kind of collect the observations across time and then kind of put it together into something that makes sense. And the video, that's why recording the video is so helpful, because allows you to do that pretty easily.
And as you're thinking about those different types of polyps, does that you mentioned that maybe not in the moment, it may not necessarily change treatment options at that time. You're saying that if as you look at it over time, that the type of polyps might dictate treatment options, at the second or third visit. Is that what you mean?
Basically, in particular, okay, so in Southeast Texas, most of the polyps are going to be eosinophilic. But occasionally, we'll have patients who we do all the usual things for, and they just do not do well. I'll go back and look at video from the OR, from in clinic, and then it'll be, oh, this is a neutrophilic polyp, and we just completely missed it, and it gets treated differently. And that's why, steroids don't seem the same way. It just is a different picture. But in a busy clinic, it can be difficult to realize that. And I think there's, kind of on a phenotypic level, there's a lot of overlap in how their endoscopies look at any one moment in time, right? So for those patients who are not doing well, I'll try to correlate, again, across time, what each treatment does and how their endoscopic appearance will changes across time. That's why the recording is helpful.
Yeah, for sure. The picture is worth more than 1,000 words for sure.
Right. Exactly.
And, like, with your hat of Vice Dean of Clinical Technology, do you see a role are we already using AI for some of this longitudinal endoscopy or imaging or videos in response to medications, and then fitting that with some of the immune, like, the type of are they responses or
I know there are companies looking at an AI endoscopy for sinusitis. They're mostly aimed, I think, at primary care docs, actually. So not really us. And so the idea is you have an AI algorithm reading an image that says, yes, this patient has sinus disease or not. That's really the limit of it. I mean, because the problem is doing an AI model for something that is your training data set. It's only as good as your training data set. And you would need thousands to be able to come across with this longitudinal kind of journey of what an endoscopy looks like. It's too much right now to do that.
moving on to a workup. Can you tell us a little bit about sort of next steps when you consider imaging or, other testing?
Yeah, so I'll get a CBC with differential, mostly looking for peripheral eosinophil counts to see if they have a systemic eosinophilia. For a while, I was using peripheral eosinophil counts to sort of guide my steroid treatment. Don't really use that as much these days, but it is a data point that helps us confirm a little bit about what's going on. I'll check a total IgE level as well. Again, high IgE levels are associated with allergic fungal sinusitis. And then I also will check a RAST inhalant panel, mostly looking for evidence of type 1 hypersensitivity against fungal aeroallergens. Not so much concerned about the standard aeroallergens in this patient population, but it's part of the panel and it's sort of baked into it. But that's not really going to help us much for these patients.
So you send them to the lab for that.
Yeah, so it's just a blood draw. We try to get it the same day before we
Oh,
start
nice.
treatment. Yeah, so just I drop down the Quest or whatever labs in the
Right.
building and get that done.
Do they need imaging right off the bat? Do you get a CT scan the first time?
Typically, it depends if they've been treated or not. If they've been quote unquote maximally treated, we'll just jump to a scan and get that done. If they've not been treated, we'll start some type of treatment and then bring them back typically in a month with a scan. I think they all need a scan, even if they even a polyp patient has a good response to the initial medical treatment needs a scan because you need to know if there's a mucocele, if there's a high load of eosinophilic debris. Those patients are set up for failures and complications. I mean, I've treated patients who've had, vision loss from allergic fungal sinusitis, and it's because it wasn't picked up soon enough. And you can't tell just by looking in their nose with a scope. You're looking at the tip of the iceberg. You have no idea what's going on in depth.
Got it. So everybody gets a scan eventually.
Yeah,
And
they all do.
yeah.
We run a high resolution scan that's good for navigation on everybody, one protocol. I try to work with the same imaging center as well consistently. We have a printed out sheet. Whenever we go someplace else, half the time they do it incorrectly, even if we give them printed instructions. And I tell that to patients point blank. And even if it's a pain for them to come back to get our scan done at the regular place, most of them will come back for it
Yeah, so that they don't have to end up getting
too.
ultimately having to
Yeah.
redo it because it was
Rescan.
done
That's the
wrong.
worst.
Right.
Yeah, it's
Yeah.
the worst.
And when you with as far as your treatment for patients who are treatment naive, is there a particular, go-to treatment? Like, do you like to do oral steroids from the get-go or just budesonide irrigations, or how do you decide how aggressive to be with your
If they
steroids?
have, significant polyp burden on one side or both sides, I will give them a round of oral prednisone unless there is a strong contraindication. Depending on the polyp burden, it could just be a 12-day course of prednisone, starting at 40 milligrams and then dropping by 10 milligrams every 3 days. I'll pair that with antibiotics. I don't think the antibiotics do very much in many patients. But if you're thinking about there's a possibility of surgery, that's one of the check boxes you got to hit, right? So we'll do that. And then typically we add on a topical steroid as well, particularly as the prednisone is coming down, because the prednisone will open things up and then allow budesonide irrigations or exhalational delivery of fluticasone to get in. And so I'll prescribe that to start, and then they'll come back, typically within a month, maybe 6 weeks with that scan, and we kind of see how they're doing at that point.
And what, antibiotic how long are they on it for? Like 30 days, 2 weeks? And what do you use usually?
3 weeks is typical. I mean, I think it's arbitrary, but I say 3 weeks. And then what's interesting is with that regimen, most of the patients will feel better, right? It's just a question then of how sustainable the improvement is when the prednisone is off. The other thing, but I think what you get in some patients, when the prednisone opens things up and the topical steroid can get in, they continue to improve beyond those first few weeks, right? Because the steroid only hits the surface. The inflammation improves, it opens up a little more. Then there's more surface for the steroid to hit. So they can improve actually for weeks, maybe even months after initiating the topical steroid, after the sinuses have been opened by the round of the prednisone.
And which antibiotic do you like to use?
Amoxicillin clavulanate, usually, occasionally doxycycline if they're allergic, or they've been on amoxiclav recently. Quinolones are an option too. As far as antibiotics, I will get a sample and typically send it for NGS sequencing as well. And to identify specific targets, I think it just makes a little bit more sense if you can do that.
Do you wait for that to come back before you start anything? Or you kinda
Dep
do it
Depends on the
in
quality of the sample. If it's a good sample and then I will wait. It takes a few days. It's much more precise. Patients are accepting of that. You can explain to them that you're making a scientific choice about antibiotic selection based on the presence of bacteria. I am careful though when I talk to patients to not call it a bacterial infection, because probably not. And that's a whole kind of rabbit hole that we can get into. But it's a factor that we can modulate with treatment with antibiotics, which probably drives the inflammation in some way.
And when you're talking to patients about just polyps in general, how do you explain nasal polyps? Because I think sometimes patients hear polyp and they think, about polyps in other parts of bodies, like a polyp in the colon, which, could be precancerous and that you can just remove. Or they might say, like, can't you just take it out? And you kind of have to have that conversation about the uniqueness of nasal polyps. What does that conversation look like for you?
Well, a lot of times you can watch the patient's reaction if they think it's something like a colon polyp, right? And then I'll just say point blank, this is not like colon polyps. It's a completely different game, just to take that off the table if I get a sense that they're just super nervous. What I do explain, though, it's just basically about inflammation that is triggered for unclear reasons in a specific patient. And I'll even go further and say it's like a lot of chronic diseases that, everyone experiences, like hypertension. Why do some people get high blood pressure? Some combination of a genetic predisposition, some bad luck, and some ill-defined environmental trigger, right? Almost any chronic illness falls into that category. And if you go, it's very hard to go deeper than that in any one patient without doing, these exhaustive studies that are not really clinically relevant. And most patients will accept that type of explanation.
It can be a hard conversation though, because sometimes for some of them, if they're young, it's like their first chronic, disease where it's like, "Oh, this is something now that's I have to consider lifelong or take care of." It's, something else to think about, and so I've had some patients where that it's taken several visits, to really understand that, "Oh, this is something that isn't just gonna go away," even, in multiple discussions, about it.
Well, the advantage there is you're dealing with a clean slate, though, in terms of what that patient's expectations are.
Yeah.
I mean, some of my favorite patients are, kids I saw in high school, and now they're through college. They just come back for checkups. They're allergic fungal sinusitis, and they completely understand the disease process. They don't cold all the time. And it's very cool. They come in and they'll show pictures of their kids now, which is really neat because I knew them when they were in like ninth grade. And we managed them through the whole way, and the disease kind of burned itself out, and they're just doing fantastic.
Going back to, we talked about kind of that initial treatment with steroids. You mentioned that there are some patients that maybe can't have steroids. Can we elaborate on that piece a little bit more?
I don't think there are very few absolute contraindications to almost anything that we do. That patient group would mostly be diabetic patients. And even there, you can go down and say, do you check your glucoses, get a sense of how severe their diabetes are, work with their endocrinologist. So it's manageable. You just have to do a little bit of extra work. If it looks like they're not a candidate at all we can rely on are the topical treatments. And I think that's fine because the amount of absorption you're going to get from a topical steroid treatment, it's not zero, but it's not going to be enough to trigger significant hyperglycemia, right? So it's manageable. But that's not that for some reason it's not as common today as it seemed to be years ago. I don't know if endocrinologists and primary care doctors are better at managing diabetes or we're using less prednisone. But it's just it seems to be less of an issue today compared to 15 years ago.
Yeah. And what about patient preference? Like, do you have people who are just, you mentioned prednisone and they're just like, ooh, I don't want to take steroids. Is that,
That comes up whenever I start the prednisone. We have some, standard discussion points around bone metabolism, irritability, hypertension. Weight gain is a thing that gets most people. I just review the pros and cons. I mean, we may go more toward a little bit of a shorter course than a longer course, but I explain the idea that it's just to sort of jumpstart things so that we can rely on topical. And most people will go along with that.
and is there anything else? Like, have you ever had patients who say, like, is there anything I can be doing about my, lifestyle, diet, environment to help this?
It depends, really. So some patients will look up and they come in and start talking about salicylate-free diets. If you have aspen triad, and salicylate-free diet does make sense. The problem is very few people can do it because all you can basically eat is cardboard. It's almost an impossible diet to stick to. Modifying those behaviors sounds great, but in practice, people can't sustain it. And then the other issue is that people are going to make a major effort there. I think we should be able to tell them, yeah, this is going to make a big difference for you. And we really can't, right? And so they would go through all this effort, end up exactly where they are. That's not helpful either.
So now we have the patient who, just going back to the primary polyp patient who saw you in clinic. It's been about 6 weeks. They did the steroids, they did the rinses, they did the antibiotics. They've come back to you with a scan and they're feeling better, right? What's your next step? How do you kind of, counsel patients and how do comorbidities play a role, like comorbidities such as asthma or significant allergies, if they do have those?
Okay, so I think a lot depends on the CT scan. We want to make sure the sinuses are safe, meaning there's no mucocele, no bony erosion, nothing, kind of crazy going on. So assuming the scan shows quote unquote safe sinuses, we can just talk about, I think, what the likely disease course is. So we would keep them on the topical treatment that they're on and see how they do. And if they lose the progress that they made, there would be some kind of escalation. Then talk about that escalation Could be surgery if it's soon. It could just be another round of prednisone in 2 years. Really depends on what it is, what happens, and what their prerogatives are. So that's the general thing. And most of the time, most patients will be better after that initial treatment. If they're not better, symptomatically they're the same, then they're just going to go to surgery, I think. Because the surgery just allows essentially a complete reboot, and you're starting fresh and just lowering the disease burden so much that topical steroids or steroid delivery devices can control the patient's symptoms.
Do you have like a number of rounds of steroids in a year or every certain number of months that you're like, okay, we're doing it too often and maybe we should do surgery? Like they respond, but then the pelvis returns so quickly. Do you have anything like that in your experience that you follow?
It depends on the type of symptoms between the flare ups, right? So if a patient's requiring steroids like 4 or 5 times a year, let's say, they're basically never asymptomatic. But if it's like once a year or once every 2 years, then they're getting large periods of being symptom free. So it's that duration of being symptom free that drives it. If I treat the patient, they get better and for like a few weeks, and then 3 weeks later, they say, I'm getting worse again. I'm likely to recommend surgery just to escalate to that, just to break the cycle. At that point, patients are sort of on the program, understand this is a chronic disease process, understand the role of topical steroids, and they're great surgical candidates because they're likely to sustain the postoperative treatment.
If patients with allergies or AERD or asthma, how with those other comorbidities, how that might change your management for the patient with polyps?
So those are three separate items, three separate buckets. When you say allergy, I am thinking of type 1 IgE mediated hypersensitivity. I don't think that plays a large role in nasal polyps. I mean, part of it is just intuitive. You think about it, if your nose is full of polyps, you have no aeroallergen exposure because there's no aeroallergens getting into your nose to trigger it. When you look at the what we know about polyp mechanisms, it's not really IgE mediated in the sinus lining. So it's just, I don't think that's super relevant. Now, there are patients at whom you reduce the polyp burden and suddenly the nasal lining is exposed and can get aeroallergen, reactivity. But that's relatively easy to treat because you're going to have them on a topical steroid anyhow, and you're getting it into the sinuses. It's going to get into the nasal lining as well. You have it covered. As far as AERD, that is a marker for much more difficult to treat disease, both from an asthma standpoint and from a sinus standpoint. And I will tell patients point blank that upfront that we're going to need to be much more aggressive with this, and we can expect, just more difficult to control the problem. Now, what's interesting about that, sometimes you do the standard treatments like this, and those patients just cruise right through it. You can't really predict with 100% certainty that every AERD patient is going to fail. And so I've been surprised occasionally over the years how well some of them do. We will talk about aspirin desensitization in those patients. That's difficult to get, but I've had some patients who do really well with that. I'm a little bit concerned that's sort of a dying art in terms of a lot of allergists don't really want to bother with it anymore. And then in the AERD patients too, I'm more likely to bring up biologics sooner because, they just have more recalcitrant asthma and more recalcitrant sinus disease. But I wouldn't launch that to start with. And I think you mentioned asthma as well. Sorry for rambling on here. So for asthma, so I treat a lot of asthma. Most of these patients, have an inhaler. There aren't many people and many pulmonologists or allergists who want to treat asthma, it seems like. The pulmonologists are focused on running the ICUs, and their clinic practice is sort of an afterthought, like a side gig or something. So these patients can't get anybody to manage their asthma. So I'll prescribe their inhalers, occasionally adjust the dose, give refills because they can't get their pulmonologist to do the refills because it's a pretty simple thing to do. If they're not responding well to that, then I obviously have to escalate and get a pulmonologist involved directly. But for the routine maintenance, I think as ENTs, we can manage that.
Back to our patient who maybe is a candidate for surgery now, you're starting to think about surgery. Is that what extent of surgery are you doing? And do you ever think about biologics earlier as an alternative to surgery? Is there a patient population that is a conversation?
Well, let's talk about the surgery first and maybe the biologics issue. So I think the important thing about the surgery is the first surgery is probably the most important one. We suspect that's true, especially for allergic fungal sinusitis patients, but I think it's true really in general for all of these polyp patients. It has to be comprehensive in terms of making sure that all the sinuses on the involved side that have polyps in them are cleared out because you really want to get them down to a true polyp zero state, right? Because that's your new baseline, right? And you don't want to have any pockets where there's a nidus of eosinophilic inflammation just kind of blocked off from topical treatments. So the surgery, I think, needs to be comprehensive. That doesn't mean that every patient automatically gets a drill out. I think that's overkill and too dysfunctional. Most of these patients with polyps, the frontal recess is expanded by the polyp. It's almost done the work. You just have to spend the time to make sure that all the little compartments are open and cleared out. And so, but we have the technology to do that safely, reasonably well. And so, but what the surgery does is set up the patient for post-operative steroid delivery. You can place mometasone implants at the time of surgery as well, but the sustained delivery of steroids into the cavity is important. Now, for the biologics question, I think it's an interesting one. Over the past 3 or 4 years, there are a couple patients who were sent to me by allergists in town who were started on biologics, and their request was they wanted their sinuses, quote unquote, cleaned out so the biologics would work better. And so they were started on biologics basically the week before I would see them in the office. And in that, very small number of patients, the surgery seemed a little bit different in terms of how their eosinophilic mucus looked. It was just a different consistency. It's tough to put into words, but it did look different. But the problem with that approach now is there's no data to show that, you choose your favorite biologic, you give them 1 or 2 rounds, you do surgery, you're going to take it off, whether that actually improves outcomes. That study in the US will never happen because the people who fund the research do not want to fund only 2 rounds of a pharma treatment or 1 round, right? So we're kind of trapped there. It's an interesting idea, but I don't know how far we'll be able to take it.
And I know you said that for these patients, when they started the biologics 1 week before, the mucin was different. It was hard to explain. Was it thinner, stickier, less copious, less amount?
It looked like it was, in my mind, depleted. It was stringier. It had the consistency, this is a little bit gross, but sort of like of raw bacon in terms of how it came out in the stringy sheets. It was only like 3 or 4 patients. I mean, so it's hard to know exactly, what I was looking at, but
Does it make the surgery easier? Kind of the corollary would be like, using preoperative steroids to decrease inflammation before surgery. Is it
Are they easier to suck out?
wasn't easier to suck out. It was easier to grab. It wouldn't go through the suction. You had to grab it. I mean, that's an interesting idea. But I mean, the reality is that, because I don't keep patients on long courses of steroids before surgery. We can do the surgery without the steroids. We can do the surgery without the round of the preoperative biologic, right? And because our techniques have gotten better, right? We can see the issue with the steroids originally was at a time when your cameras, if you were using a camera versus looking with your eye, the camera was only, basically less than DVD quality in video, right? And the picture was dark and you couldn't tolerate any bleeding. Now, with, 4K cameras, if you use intraoperative topical epi, bleeding and visualization, I think we've kind of checked that box that we can see. So we don't need to use preoperative steroids. I don't see what the advantage of offering a very expensive drug, even for 1 or 2 doses, is going to give us beyond that. And to show how many extra patients do you need to treat before you actually make a difference. So I don't really see the value proposition there based on current technology and currently how we're doing the surgery.
And do you think that there are patients who can avoid surgery by using biologics and that just never end up in your office because they were started on biologics and then their polyps got
Maybe
so much
for
better?
asthma or for other reason, and
So that's a good question, but very hard because it's like an unknowable from an ENT perspective because we're not seeing those patients. I do think that's happening. Allergists and pulmonologists are prescribing biologics at higher rates than we are as ENTs. And so there's a whole flow of patients that are no longer coming to our offices. That's a problem for our specialty, a significant problem. Because we fought in the roughly between 1995 to 2005 very strongly as a specialty to control this disease space. And we're losing control over that disease space now. If you look at the indications for the biologics, it doesn't say that patient had prior surgery and has a recurrence. It just says they have polyps above a certain grade. That's the indication. And so we talk that when we have our meetings, we say, oh, this is reserved for people who are not doing well after quote unquote conventional treatment, which includes surgery. But that's not what the FDA indication says. That's not what the allergists say or do. They're capturing those patients and keeping them away from us.
So, do you think we should be offering it as a first line before surgery?
No, it's ridiculous. I think it's ridiculous. Because we've gotten really good at it, right? And, if you look at how, there's a whole issue, it's sort of a separate topic, but how drugs are developed in this country, they are developed to get an indication, right? It's not really developed in the sense of what role they should play in a chronic disease process. Nobody really looks at that. It's up to the specialty societies to try to do something. But, the standard things that we rely on are pharma funded and, pharma is interested in just getting the indication and driving sales. Their interests here do not 100% align with physicians who are responsible for the care of these patients.
So, Dr. Citardi, where do biologics play a role in the management for your patients with polyps?
So I think where they play a role is when our quote unquote conventional treatments are failing, right? So patients have had surgery, they're on topical treatments, they're compliant with those treatments, and then they're still failing. Many of those patients also will have asthma. But we also, as ENTs, I think we need to step up and own the process because no one wants to see the patient coming back after sinus surgery and they're just struggling and not doing well. I mean, it's sort of frustrating, right? But the reality is, through getting a good history, educating the patient, looking at their endoscopy and doing debridements in the office, we can come up with regimens that emphasize topical drug delivery and keep those patients off of biologics. But we have to work with the patients who are not doing well, and that's hard. I mean, it's not fun. But the reality is that's what that as ENTs, I mean, we kind of prided ourselves when we were doing our residency interviews that we were going to be both physicians in the office and surgeons and be both, right? And if we're true to that, we've got to sort of embrace that part of the practice.
Yeah. So, can you tell us a little bit more about steroid delivery? We all kind of think of topical budesonide. Is there a role for steroid eluting stents at the time of surgery or in your office or in your practice?
So I'm going to say a strong yes for that because it's a way to get basically steroid to target in a very reproducible way and predictable way. You can think about the sort of standard 370 microgram Propel Mini, Propel Contour versus Sinuva, which is a much higher dose. The Sinuva mometazone implant was designed for recurrent polyps after ethmoidectomy for delivery in an office setting. And so I will offer that to patients quite a bit when they're not doing well. And the conversation is basically we can, do this procedure in the office, place this dissolvable device versus putting you on a biologic, which is probably an indefinite commitment. And most patients don't like the idea of an indefinite commitment to an injectable medication. I mean, all the studies seem to show that when the patients will respond to your favorite biologic, but when you stop the treatment, the symptoms quickly start to return. It's not what we hoped it was going to be. We hoped that you would treat them for a brief period of time, the system would reset and you'd be done. That's not what it is. They need to be on it continuously. Now, some of that might be because of how the studies are designed, right? It's if you're pharma wanting an indication for your billion-dollar drug, you don't want to show that you only need a finite treatment course. You want it to be open-ended. But all the available data and the kind of the anecdotal clinical data shows that when you stop the biologic, the underlying disease process reverts. And so when you make that choice to patients, many of them will opt for, having a mometasone implant done in the office.
And when they do the implant, they don't have to do budesonide irrigations, that the implant's gonna do the work for them?
While I tell them they should still do the budesonide irrigations, I'm not sure they're as compliant with that as they should be because you can check when they're asking for refills. But what I say is that the implant kind of gets things going. It's not going to be an indefinite presence, right? It's 90 days and probably the first 45 are the most important. So you open things up again and then it allows again the budesonide to get in. It's sort of the same idea behind the original polyp surgery. Kind of open things up, reduce the disease burden, and then let the topical steroids take over again.
And just to play devil's advocate a little bit, so to the patient who's saying, "Okay, I'm going to be needing topical steroids indefinitely or doing this shot indefinitely," like, why is one better than the other?
Well, I think the main difference, the thing that's most understandable from a patient perspective is the systemic effects, right? I mean, one of the unique things about what we do is that our body space is accessible to the outside world for diagnosis and follow-up evaluation. It's not like asthma where looking in the lungs requires a bronch, or if you're treating the GI tract, it's a whole different game. And so we have a unique opportunity to sort of assess pretty much everything that's going on. And if we can, in my mind, it's all about drug to target, right? And we have an accessible target in a way that a lot of our other, medical specialties don't.
And in terms of the steroids, when do you decide when you're gonna place a steroid-eluting implant? And so which patients are you gonna place them in? Is it part of all of your surgeries initially that maybe you'll put a Propella and see how they do, and then they come back, then do the Sinuva, or and how do you decide which one to use?
Okay, so we're talking about polyp patients predominantly, so let's kind of focus on that. So for polyp patients, I think the mometasone implant, the Sinuva, is the better choice because it sticks around longer and it's a higher dose of mometasone. If I have a patient who has significant polyp disease, I will do that in the hospital. Our hospital is a 340B, I think is the designation, which means it gets special pricing on Sinuva because Sinuva is a drug and not a device. It's something like that. So the cost for us is the same for Sinuva versus Propel Mini or Contour. Now, so large burden polyps, I will use Sinuva place at the end of surgery. That is not in accordance with the FDA indication because there's an FDA indication about wound healing that you can't be in an open wound to place the Sinuva, something like that. That doesn't bother me a whole lot. I mean, we place steroids into open sinus wounds all the time. I mean, it's kind of silly, really, but I will place it at the end of surgery. Those patients, I think, do super well because wherever the Sinuva is sitting, the cavity normalizes very dramatically. Now, the concern is also about the crusting issue. You have to be really careful to debride it, get the crusting off.
Yeah, and from a cost standpoint, is it more cost effective? Like, even let's say you had a patient who has severe disease and they need basically a new Sinuva every 3 months, and it works and it helps them. Is that still more cost
If
effective?
we're doing a Sinuva every 3 months, I would say we're failing.
Okay.
There's something wrong, right? You got to That's too much. But I'm think what the frequency I'm thinking about is every 12 months, 10, 12 months. It's like once a year. I think that's reasonable. And that's certainly cost advantageous. If patients requiring one every 3 months, something's wrong. And I think that's a true treatment failure in terms of, a candidacy for a biologic. But I also would be concerned that that patient may have a cell of eosinophilic mucus that wasn't completely opened. So I would rescan them to make sure there's not something else going on. But every 3 months, I think is just too much.
I think I throw that out there because it's a like a 3-month supply. It's like 90 days, right?
Well, right. So the device delivers drug over 90 days. Most of the release is in the first 45 days or so, the first half of that. I think clinically, what I've observed is that the effect seems to last longer. And I think it's because they're still on the budesonide irrigations or the mometasone irrigations. They're getting other treatment. It's just they get that initial boost, keeps things open, and then it's access for the long-term low cost treatment.
Do you use, the shorter acting Propels in your practice for other patients?
Yeah, so for non-polyp patients I'll use it in the OR for many of them, not all. For patients in whom I'm managing a frontal sinus stenosis, we'll use a contour in the office sometimes. More focused, sort of focused obstruction of a particular sinus.
So for, like, scarring, synechia.
Yeah, more scarring, particularly for the frontal recess, right? There are some patients whose frontal recess always is a little bit more swollen, and occasionally we'll do an office procedure to tune it up, and I'll slip in a contour. Again, just to give a boost of steroids into that area.
How does cost and insurance coverage come into the decision-making part of it? Are there some patients where, depending on their insurance coverage, it's gonna be impossible to try to do Sinuva, or it makes more sense to do a biologic? Does that come into play or not really?
Well, I try to be agnostic to that when I'm making recommendations to patients. I don't think because it's a slippery slope. When you start doing that, you're making decisions about what it's almost mercantilistic, what's going to generate the most revenue for your hospital or your practice. And so I try to avoid that. Now, so what I do practically is not really consider that, make recommendations. And then if something can't get approved, go through all the appeal process. If we hit a wall, we have a discussion with the patient, say, well, you can try to pay cash. You can go to here's the next best option. I mean, what do you want to do? And then just advocate for the next best option.
In terms of your follow-up, Dr. Citardi, going back to our patient, you've seen the operate on the patient. When do they see you back? And then how do you follow these patients? Is it every, like, 3 weeks and then, 3 months type of thing,
Yeah,
or
so the typical ground rule after sort of a conventional image guided FES for nasal polyps is 2 visits in the first 2 to 3 weeks after surgery. And then at that second visit, I can get a sense of who's going to be a frequent flyer versus not. At that point, we start them on the steroid irrigations or exhalational delivery of fluticasone if the cavity is not crusty or dirty in a sense. If I think they're a frequent flyer, I'll bring them back in 2 months. If I think they're going to do okay, I'll say 3 to 4 months. But for the first couple years, most patients are coming back every 3 to 4 months for just routine checks. I encourage them to come back regularly during that early period, because they will feel great, but they could have a significant relapse and not have symptoms because the cavity's wide open. You only get symptoms when things kind of fill in to that extreme level again. So I encourage them to come back. And I tell them about that too, because it's an incentive then to tell them, like, even though you're feeling good, you got to stay on the irrigations. It's super important. And I'll use the analogy of like blood pressure medicine. Like when you take your blood pressure medicine, your blood pressure is good, but that doesn't mean you stop your blood pressure medicine. And that most people get that. I mean, if they don't, then, they're going to do whatever. But most people get that. But I do want to see them early in that first year or two when they're doing well, because, if there's a smoldering infection, if they have cystic polyps, those are all things that we can intervene with in the office that I think prevents a progression to a full-blown symptomatic relapse.
And in patients who in that small population who are on a biologic because they're just had severe disease that wasn't controlled with topical steroids, are they coming in at the same frequency? Is there anything special or anything additional to think about in that group of patients?
No, I try to use the same frequency, basically. I mean, I try to be consistent. At that 2 or 2.5 year mark, when they're doing well, I may start both groups, stretching them out to 6 months. I mean, the reality is there's a certain amount of attrition because people move. I also think over long periods of time, the disease process sort of burns itself out. Nobody ever really talks about that, but I think that certainly happens. If you have someone who has polyps at age 18, they don't have the same kind of polyps 20 years later. And those adult patients who develop polyps, their natural history is different, right? But we don't really have much information, that kind of longitudinal follow-up.
In terms of, as we start to round things out, where do you see future research, future gaps in terms of, our overall what we know about nasal polyp management?
The main knowledge gap is how do you deploy all of these options now, right? And we need a different paradigm for assessing that. We need to think about not just achieving an outcome, but for an incremental cost or expense or complexity, how many extra patients do we have to treat before we get one more better? Almost like a marginal cost type of analysis. Currently, that's not how we do research. But again, from a system standpoint in healthcare economics, that's what's sorely needed. Otherwise, we're flying blind, or we're relying on industry-sponsored data to drive care delivery decisions, which is incomplete. I mean, there's too much of a conflict there. The current regulatory regime is not favorable in terms of what national policy should be on these issues. And that's not just an ENT thing. It's across the board. Just this week, I had some discussions with UT System healthcare economics people about expensive pharma drugs in Texas. And they're seeing this explosion of cost because people are being always moved to the next new expensive treatment without really figuring out, well, who really needs it? And so that's the gap. I mean, I don't know how we really fill that. I mean, that gap right now, I think the first step is to admit it's a gap. We're not really talking about that much, but I think that really needs to be, you got to admit you have a problem first before you can start developing a solution. So we got to admit there's an issue there.
Well, this has been a really, really great conversation. Thank you so much for taking the time. If listeners want to learn more about you or follow you on social media, are you on Insta? Are you on X? Are you
I have an
tweeting?
X account that's not active. I'm most active on LinkedIn.
LinkedIn. There we go.
That sounds good.
I'm very easy to find.
Awesome. Thank you
Well,
so much.
thank
This
you
has
so
been great.
much. Learned your
Great.
time.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.